thank you so much for joining us all the way from Australia to share your excellent trial. I can't wait for the results to come out. I think we're all probably desperate for that. But it's great that it's started, and I hope you will be able to go international with it as well, and hopefully get the patients recruited to it. Question first of all from the audience, Lisa Lichtenstein. In the study, you said radiation after 24 hours of surgery was done. I think this may have been relating to keloids, if I'm right. But the question is really, do you have to wait until the skin has healed after surgery to do the irradiation?
Yeah, well, certainly in those other indications like heterotropic ossification and keloid, one of the dogmas is the granulation tissue really starts kicking off after the 72 to 96 hours. So that's kind of what we used as a template. And I guess one thing that's going to keep on coming back here is we still keep on going around in circles about where there may be harm or benefits or whatever. And I guess what we're really trying to do is be very careful about data collection regarding toxicities, quality of life, functional endpoints, you name it. So I think worst case scenario from this kind of trial, we're actually going to get some really good data to actually inform patient decision making and clinician decision making about what the real risks and benefits are, both in the post-op setting or post-intervention setting, but also following radiotherapy in these different scenarios.
So quick question from me. I noticed that you didn't have many in the needle aponeurotomy arm yet. Is that because that's not a very popular treatment in Australia, or do the patients just not want it? Have there been any barriers to recruitment there?
Well, I think probably the main thing has been just getting surgeons on site, because a lot of it's been patient-informed referral through primary practitioners with just the early prevention sort of scenario. But we have got a sort of a critical mass starting to grow, and we're hoping once we go international, we're looking at hopefully getting Grosjean up and running in the near future. That will also snowball. And as I guess you probably appreciate, Dominic, that it's one of those things that sort of it's kind of fringe science until it becomes sort of so much momentum that there's almost like a fear of missing out, and we're sort of reaching that tipping point in Australia now. Good.
Paul.
Thank you, Jarad, for this excellent talk. I had the pleasure to meet Jarad, I think it's 2 years ago, in 2019, when we had a plastic surgery conference in Melbourne. And I had the opportunity to give a few presentations about Dupuytren's, among others, about needle. And what I experienced there is that collagenase was still a very important treatment. And the surgeons are, just as everywhere on the planet, they're very hesitant to start doing needle fasciotomy. And I don't know exactly why that is. I think that the collagenase was marketed much better than the needle fasciotomy, so that is a problem. But now that collagenase has been effectively taken off the market everywhere except for the US, it is probably going to take off more. And as you said, we hope to join in the end of the year, or hopefully early next year, and then we'll help you raise the numbers in the needle fasciotomy group.
Good. Professor Siegenschmidt has sent us a question. He's worried that 6 weeks may be too close for your second round of radiotherapy. The skin radiation reaction may not have resolved by then.
Yeah, well, that photograph I showed was of one of the patients, 6 weeks after their first lot of radiotherapy, and they had no sign of any erythema or skin changes. I guess once again, this is why we're collecting this kind of data. We've allowed the 4 to 12 week break. That's all going to be recorded. So if we do find that there's a increased toxicity with a shorter interval, then that will inform decision making if and when this gets implemented further on down the track. I guess similarly, coming back to the previous question about the field, we've really allowed everything from sort of involved field to whole fascia, and we've recorded that as well. So we'll also be able to get some data really about benefits and or risks of being too broad or too narrow, both as far as disease recurrence as well as toxicity and wound healing issues that might be associated with those different approaches.
Richard.
So just coming back to that point about the field. So just to clarify, in the series that I presented, there are a few differences between the way that the radiotherapy was given and the way that you're giving it. Obviously, the time difference between the intervention and the radiotherapy is very different. And I have to say, my practice is to wait for a number of weeks, particularly after a fasciectomy, to look for healing. So I find it just very interesting and in some ways very brave that you took the decision to do it 24 hours afterwards. So I think it's amazing looking at a patient and you saying that their scars are so good, but I'm assuming that that means that you've not yet anecdotally noticed any wound healing problems yet.
Well, probably more tellingly, we outsource all the follow-up to hand therapists who are blinded to radiation or otherwise, and now we've treated a few dozen of these patients locally. Even a year or two down the line now, I've had a chance to just sort of debrief with them about whether they've noticed really anything, and they really can't tell who's had radiation and who hasn't. And I guess even more tellingly, we're now actually finding the opposite problem where the surgeons have been so pleased with the outcomes that they're just telling patients they need to have radiation. And so when they come, it's actually becoming challenging to randomize them to being observed, which is almost a good problem to have in a way.
Yeah, that's very interesting. The other question, and you may well have answered it, is that you could see in the series that I reported, the actual surgical field only received the first phase of 15 Gray in 5 fractions, rather than the rest of the hand getting 30 Gray in 10 fractions. But am I to understand it that you treat the surgical field with the 2 phases?
That's right. So you treat exactly the same both phases.
Right. Interesting.
So related to this, Jane Mitchell wants to know what's the radiation dose that you're delivering?
Yeah, so it's similar to what Richard discussed about the 30 Gray and 10 fractions with a break in the middle.
Okay, so just as has been described before. David O'Gorman has said, are there any collaborators in Canada? If not, let him know. I can put the 2 of you in touch after this for sure. Professor Sagan-Schmidt has a couple of questions about the needle aponeurotomy arm. So first one is, what will be the prognosis of the needle aponeurotomy arm? I think this probably means what kind of a difference are you expecting? What are you sort of powered to detect?
Yeah. So as I mentioned, we've gone for a hazard ratio of 0.5, so a halving of the risk of recurrence, and the definition mentioned before by Professor Verker of the 20% active extension across all the joints or flexion. so we've tried to sort of marry into the sort of surgical literature with that, and we've sort of set the expected relapse rate over 5 years at about 50%. As you know, all this data can be a bit rubbery when you review what others have reported, but that's what we sort of landed on for the needle aponeurotomy recurrence risk over 5 years.
Okay, great. And it's just after primary needle fasciotomy, is that right? Or are you accepting people who've had their second or their third needle?
Yeah, so in a way, in the primary, the prevention sort of arm, we want completely virgin hands. So unlike the series that Richard sort of presented from Professor Schmidt, where it was really almost like a secondary prevention type approach, being given many months afterwards, we're kind of going for the completely de novo setting there. Whereas in the adjuvant setting, almost the more interventions they've had, the better, because we see them as being the most high risk patients, and we really want to kind of, they're the target group that we actually see the most potential to, that radiotherapy may have a beneficial impact.
Dominic, can I ask a question?
Of course.
Jarad, I would like to come back to the radiotherapy after surgery. I often leave parts of the wound open, especially in the palm. On top of that, you sometimes have circulation problems, so the skin may slough and ultimately become a scab and fall off. Does that stop you from radiating so soon after the surgery?
Well, certainly our patients don't get randomized until after the surgery. So the surgeon has to have achieved a flat hand. They've got to be kind of comfortable with the wound management and everything before the coin gets flipped or the patient actually gets formally registered into the trial. So as you say, if the surgeon feels that some sort of more complex multi-stage type approach is going to be necessary, then that's probably not the right patient for this sort of trial. I guess the short answer is we haven't sort of been going into that kind of patient group.
Okay.
There's a comment on the Q&A from one of the surgeons, David Hunter-Smith, who says patients are often keen for radiotherapy and just don't want to be randomized. They want the radiotherapy. So that's an interesting insight. It sometimes can be difficult to keep equipoise in trials like this, especially if you're.
Yeah, because we get an avalanche of these patients now. Like we get like. And that's why we set up the combined clinic, is that rather than having this tortuous conversation about the uncertainties and the over and over and over and over again, we kind of batch brew it now. So next Wednesday morning, we've got 20 patients coming through. We do the presentation, combined with a hand surgeon, a hand therapist, and a radiation physician, where we really just kind of lay out much of what we've discussed today about the uncertainties of evidence and how observation is the standard of care for a disease in uncertain natural history. Yeah, the patients can then make an informed choice. And if they do decide they want to have radiotherapy after all that, accepting all the uncertainties, then that's an informed decision.
Yeah, very good. Professor Siegenschmidt again is talking about additional treatments. What additional treatments do you give for your patients? So things like splints, massage, exercises, that sort of thing. I presume they're all having standardized hand therapy as part of this trial.
Yeah, well, obviously the prevention patients don't really get any of that, but the adjuvant patients get all the standard wound management and everything else that you'd expect. So that's we're trying to say on the baseline of standard care, the radiation is the only variable that we're introducing in the trial.
Yeah, quite.
Jarad, can I ask you, why did you decide on not having a sham radiotherapy as a control group? Because that would have made it easier for you to recruit, probably.
Yeah, I think that's something that we've maybe learnt along the lines that, and that's why we've got to. So there's sort of two aspects to that. The first one is from the scientific point of view. If we were dealing with a subjective endpoint like pain, like in the osteoporosis sort of trials with radiotherapy, then you really do need to have a sham arm, because obviously the placebo effect has a big impact there. Whereas since we were sort of aiming at much more of a sort of an objective functional sort of outcome as far as finger flexion, we didn't think it was going to be necessary from that point of view. But as you say, it does lead to some greater potential attrition when the coin falls the wrong way from the patient's point of view and they get randomized to observation. So we've had to really preload our counselling about patient expectations, that really observation is absolutely the standard of care. Radiation is the experimental treatment. They're going to get all the same sort of care and monitoring. And really, we try to say, like, for any clinical trial, you personally may not benefit. It's actually more about us trying to learn something, and particularly for something that's a hereditary condition, that may have some more immediate impact for family members, for instance, in the longer term. So we've really now pivoted very much towards a community service type pitch rather than a maybe individual reward type approach.
Okay, we've got one final question before we move on from Robin Starsman. And I'll take advantage of having two radiation physicians on the panel currently. Could someone speak about the difference between 5 days a week and repeat in 3 months versus 7 days per week once as a single course?
I can probably let Richard just mention that as a sort of result from the Siegenschmidt trial, since he sort of mentioned it in his presentation.
Yeah, so both of us have mentioned that trial, and that, as both of us have said, was a randomized controlled trial between 5 days worth of treatment, 3-month gap of 5 days of treatment, and then the other arm, the 21 gray arm, was 7 treatments, although each one was given on alternate weekdays, not on consecutive weekdays, and the 30 gray, where you get 2 weeks with 3 months in between, was found to be superior, both in terms of effectiveness and also in terms of side effects. So that has become the standard arm. So whilst I would say personally, I've given 21 gray to, really a very small handful of patients who have flown in and never want to fly back. So, 2 phases just wasn't practical, and it was better than nothing. But apart from that, really, if we've got the choice, for me, giving the 2 weeks of treatment with 3 months in between just is the standard dose now.
And Professor Sagan-Smith's come back to say that in his longer-term data, the 21 gray group became slightly worse and the acute toxicity was more. So that sort of backs up what you're saying. Okay, great.
Well, can I just thank you all for the opportunity to present at this forum, and it's a shame we couldn't do it in person for obvious reasons, but I'm very looking forward to hopefully the next symposium being able to show up with some actual results and meet you all in person. So thanks a lot.
Thank you, Jarad. We're also really looking forward to that, and I can't wait to see the results of your trial. And hopefully you'll make some new connections after tonight and open some new centers as well. It's my sad job now to demote you back to being an attendee only, so I do apologize for that. But thank you very much, and do stick around to the end because there is actually a prize for the best free paper. And so we'll wait to hear what the judges score on that just right at the end of the webinar. Thank you so much for your contribution.